Good morning, everyone, or as I said, good afternoon, good evening, wherever you are. My name is Johan Monson. I'm a Senior Engagement Officer here at the Institute for Health Metrics. Institute for Health Metrics and Evaluation here at the University of Washington. And I'd like to extend a warm welcome to all of you. If we can get the next slide, please. We are here today to talk about GBD 2023, a closer look at non-fatal diseases, injuries, and risk factors. This is the third topic under our GBD 2023 in Focus series, where we attempt to provide an overview of GBD 2023 results, followed by a more in-depth look at each of the three capstone publications for this round of the GBD. We have the honor today of being joined by Dr. Theo, who will be presenting. If we can get the next slide. And the next slide. And the next slide. Before we begin here and I introduce Dr. Voss, I would like to do some light housekeeping. For today's session, we're going to spend approximately the first half looking at critical findings and the associated implications relevant to the diseases, injuries, and risk factors capstone. Following this, we will have about 20 minutes or so for kind of Q&A and comments. And because of the size of the group today and so on, we have microphones muted. So we encourage everyone to use the Zoom Q&A function. If you put a question in there, it will get to us, and we can then answer them in an order where we can triage some questions that are similar and pull out those that will be most useful for this kind of live format. If any of you do not get to your question, or you realize that you want to answer a question after the fact, you can contact us at IHME at gbdsec@uw.edu, and we'd be more than happy to help answer questions. This session will also be recorded, which means that it, together with all the other sessions we've done in the GBD in Focus series, will be available later on via the Collaborator portal. But for now, let me introduce you all to Professor Theo. Dr. Professor Voss is a key member of the Global Burden of Disease Study, and he leads the non-fatal and risk quality enhancement team, which is working to improve GBD methods. Of particular interest to Dr. Voss are ways to enhance the quality of data inputs, different ways to optimize non-fatal modeling processes, improvements in disability weight measurement, and expansion of the data used to produce them. Dr. Voss received his PhD from Erasmus University, an MSc in Public Health in Developing Countries from the London School of Hygiene and Tropical Medicine, and an MD from the State University of Groningen. Prior to joining IHME, he was a faculty member at the University of Queensland School of Population Health. His involvement with the GBD is long-standing. He was part of early efforts in burden of disease assessment, and he also helped to pioneer country-specific burden studies in Africa, Australia, and Asia. So with that introduction, I will hand over to Professor Voss. Thank you.
Thank you, Johan. Good day, everyone. It's a pleasure for me to be able to talk to you about the newest round of global burden of disease results as they were recently published in The Lancet. And you'll note that I'm largely showing you graphs and maps from the publications, but talking to them so that I can illustrate some of the more important findings. So here you can see what it looks like for this particular capstone paper on the non-fatal estimates, the risk factor estimates, and then combining them into DALYs as an overall burden measure. So just a quick recap, the DALY measures healthy loss of healthy time through either disease and that's what we quantify as years lived with disability, or YLDs, And basically, it's the prevalence of any condition that departs from full health times a weighting called a disability weight. And those weights, they vary between 0 and 1. And close to 0 means very little health loss. Close to 1 means very serious health loss. And that then is combined with the loss of length of life compared to an ideal standard life expectancy. And so it's the YLL, years of life lost. They depend on the count of deaths and the age at death, and the gap between the age at death and the ideal life expectancy. And combining the two, we get the DALI. So this work started in the 1990s, initially funded by and stimulated by World Bank, and Chris Murray and Alan Lopez did these initial estimates that were more formally published in 1996. And you can see there was a relatively small count of diseases and injuries and geographic representation in 8 world regions and 5 age groups, and just for one point in time. That moved to more diseases in a period when a lot of this work was done from Geneva at WHO. Greater granularity in geography, and for the first time, a number of time points for which estimates were made. And that has successively grown, particularly after the IHME was founded in 2007, and successive rounds of GBD were conducted. And in more recent years, more expansion of disease and injury countries, more countries, and in particular also more subnational estimates, greater granularity by age, and making estimates year by year from 1990 onwards. And now we're up to 375 disease and injury categories, 204 countries and territories, 25 age groups, and all years from 1990. And we are already doing lots and lots of work for the next iteration, GBD 2025, which we hope to put out by next year. So these are, there's a repetition of the granularity of but we make estimates for prevalence and incidence for years lived with disability, so that weighting by severity of prevalent cases of disease or consequences of disease, the years of life lost for quantifying deaths and the health loss due to people dying, and then combining them into DALIs. We can also translate them into a single measure for a population, for a country, where we combine the amount of non-fatal health loss and life expectancy in a life table and get what we call healthy life expectancy, or HALE. All estimates are available as counts, as rates, all age rates, age standardized rates, and age specific rates. And I'll show you in the results a few examples of how to interpret counts and rates and different types of rates, and how that influences the sort of conclusions that you can draw from GBD results. And I'm doing that because I see a lot of papers that are written by collaborators that don't quite get the right balance in the arguments between what all these different measures mean. So when we look at the non-fatal estimates, we include data on prevalence, incidence, remission, severity, and mortality associated with each disease. And in GBD 2023, DALIs were informed by over 120,000 data sources, and roughly a quarter or a bit more than that were new sources for this particular round. These are the counts for incidence, for prevalence, and much smaller numbers for things like severity distributions, duration of disease, etc. Attributable burden, so that is the proportion of the disease burden in DALIs that we say is causally related to 88 risk factors. And that was informed by 59,000 data sources. And again, a very substantial addition of new data sources. Most of those are defining the exposure to these various risk factors. And then some 4,000 sources on, largely from cohort studies or from randomized controlled trials, and to a lesser extent also case control studies that quantify how large the impact is of those risks on specific outcomes. And all of this you can find back in our GHDX repository, where we list all the sources that are being used in GBD and make them available unless they are they're restricted by a data use agreement. But the vast majority of sources we can easily share. Yeah, so we've already gone over the number of news sources. We made the estimates of ulcerative colitis and Crohn's disease more explicit as separate causes rather than subunits under the disease heading of inflammatory bowel disease. We split out thyroid disease from other endocrine, metabolic, blood, and immune disorders, and made separate estimates for electrocution. 50 new risk outcome pairs, so often for the risk factors that were already part of the GBD, but new outcomes for those risk factors, and a number of new risks that were considered. If you may remember that for GBD 2021, we added, a rather, difficult category that we called other pandemic-related outcomes, and that was because the information on diseases and on mortality at the time of the pandemic was still lacking to more formally be able to quantify what the effects of the pandemic were on a number of disease outcomes, where we did have information on overall mortality patterns, but not by specific causes. But with new sources becoming available, we no longer had a need for this a bit more nebulous category. We're working hard at moving all our disease models from our more trusted or our more used modeling tool called DISMOD MR 2.1 to DISMOD AT, and AT stands for age and time. And we did that for GBD 2023 just for 4 conditions: diabetes type 1, major depressive disorder, anxiety, and autism spectrum disorders. But the ambition is for this round of GBD to migrate all disease models, with a few exceptions of diseases with bespoke modeling approaches, to this new environment, because it allows us to much better quantify how things change, not only over age, but also over time, and with greater ability to make use of predictive covariates. There are a range, as every round of GBD, a range of other methodological improvements, sometimes affecting just a particular cause. And that was, looking at a reassessment of the available information on severity of the disease, or to, uh, expand the amount of corrections for potential bias if sources use different methods, different case definitions. This is the overall scheme for estimating YLDs. It starts with a review of everything we can find in the literature or in reports or in data collection systems that we can access. That goes into a database. We then do extensive manipulation of the data. We split data that are assigned to both sexes into a male and a female data point, what we call age-sex splitting. We do a lot of crosswalking when different case definitions, different study methods lead to a systematic bias upwards or downwards of data. And we have our Mr. Burt Bayesian tool to quantify what the magnitude of that bias is. And then we make adjustments to the data accordingly. This all goes into the database. We then have a selection of predictive covariates that we bring to bear on the modeling, and for GBD 2023, largely in this mod MR, and that gives us prevalence. Then from prevalent cases, we look from survey data or literature, depending on the disease, what the consequences of disease are. And often that's a grading by severity, say mild, moderate, or severe, but it can also be very specific outcomes depending on what disease we're talking about. And then those are combined with disability weights that say for each level of these consequences, what is the relative magnitude of health loss? And that gives us an initial estimate of our YLDs. And then we have a process where we make a correction for comorbidity, and with the idea that if you have more than one condition causing you health loss, that that amount of health loss is likely not to be additive, because then you could surpass full health, as in or the total amount of health as loss, and that's an unwanted thing. And from limited sort of tests in data sources with rich diagnostic information, a multiplicative model seems to deal reasonably well with the overall amount of health loss. And those comorbidity adjusted YLDs are then fed into DALYs after combining with the YLLs from a very different estimation process. And you've heard about that in a previous session. I'll actually skip over that because I want to make sure that we have enough time for the non-fatal and risk factor estimates. Here are some links of where you can view the results, where you can pick up results that you want to download. We've made it a little harder to do so because of some unwanted massive scraping of all our results by certain actors. And so we're asking you to create an account and to log in with your personal details when you access the data. So let's look at an overall picture. This is our famous tree map. I don't know why it's called a tree map, because it doesn't look like a tree, but it shows all the conditions that are included in GBD in blue, the non-communicable diseases, in reddish tints, the um, infectious diseases, maternal, neonatal, and nutritional disorders, and in green, the injuries. And so the biggest one is IHD, ischemic heart disease. Here, neonatal disorders are the largest of this red block of conditions, and stroke is the number three in GBD 2023. But look here at the size of the non-communicable disease. It's already more than half of the total disease burden. And it varies, of course. In low-income settings, you'll see that the reddish box is much, much larger relative to the non-communicable diseases. Then these are the age patterns where you get a lot of DALYs in at very young ages. This is 0 to 6 days, so it's the early neonatal period, and that largely includes a lot of neonatal deaths from things like preterm birth, birth trauma, asphyxia, neonatal sepsis, um, uh, and uh, that is very much concentrated in the first week of life. It then has a tail of the same conditions going into later neonatal life and the first few months of life. Congenital disorders, you can see here also in blue. And then we get a pattern of steady increase over age in the total number of DALYs until about age 65, with an exception of the 2 to 4 age, where it's still elevated relative to the next couple of ages. Also, you see the predominance of infectious neonatal conditions in early life, and they become less compared to the large amount of blue of the non-communicable diseases, including these purple shades. And then the pattern of injuries, where women behave much more than men, as you can see, and have far fewer injuries than men, in particular young males, adolescents, early adult life. Injuries are a very large component of burden of disease. Then this is sort of a very large overview of those three major categories of disease burden. In blue, non-communicable; in green, injuries; and in red, the infectious neonatal maternal. And it's showing this over time as age standardized DALYs and as all age DALYs. And you can see that while the total amount of DALYs for non-communicable diseases is creeping up in all globally, but in also all 5 quintiles of socio-demographic index countries. But if you look at the age standardized rate, where we take out the effect of population increase and aging of population, there's a modest decline in DALYs that can be seen in each of those SDI quintiles. But the decline in infectious neonatal maternal is much more spectacular, particularly in low and low middle SDI countries. Whereas injuries show a modest decline over time, but not by far as much as we see for the lines in red. And then you can see, even events that happen in a small country can show up globally. This peak here that you see, that you even see in the global picture, is the Rwanda massacre. And there's a hint also of the Haiti earthquake that you can see here in 2010. Now, this is a very busy slide, and I hope your screens are big enough so that you can at least see what's happening. And this is a screen where I want to take you through the different types of measures. So you can see for different periods, and let me see if I can get rid of. Okay, yeah, for 1990, 2000, 2010, 2023, we give the amount of DALIs, and this is in millions, the percentage change in those millions of DALIs, but also the percentage change in age standardized DALI rates. And so what you can see is over time, neonatal disorders have were the prominent cause of DALIs, but have dropped to rank number 2 in 2023. And there's been a 21% change in the total volume. But if we take out the demographic component over time, then there actually has been a 16.5% improvement in DALI rates for neonatal disorders. Ischemic heart disease, also with a decline of 13.2% in the age standardized rates, but because of aging and population size and positive increase of the total amount of DALIs, and a similar sort of picture for stroke. Now, this is showing the difference between 2010 and 2023. And there are, in a number of parts of the world, worries that this sort of magic ongoing improvement in ischemic heart disease and stroke is starting to level off or even show a slightly uptick again. And that's more so in a number of high-income countries. And the people postulate that the rising obesity levels and the corresponding rather large increase in diabetes by almost 60% and 15% if we take out the demography, that is part of the flattening of the gains that we have seen steadily improving cardiovascular outcomes over the last 30, 40 years. If we look at this, if you like, real disease change, then apart from diabetes, we also see large adverse trends for depression and anxiety. And in particular, the very large increase in anxiety is very worrying, if you pardon me the pun. And there's a lot of discussion on what's going on here. Initially, there was a thought, oh, this is an effect of the pandemic, and that has caused so much disruption, and that's causing these increases. With a bit more time, we've noted that these increases have not gone away after most of the effects of the pandemic have waned. And there's some evidence, but still largely speculation, that a lot of this has to do with use of social media, and social media sort of painting an impossible picture, particularly for younger people and particularly younger women, to aspire to, and that leading to these very large increases in rates of anxiety and depression. There's also some evidence that a lot of young people are very worried about the future, due to worries about climate change, due to worries about lack of access to to housing, as housing prices in many, many countries have skyrocketed and made it very difficult for young people to get a foot into the housing market. So clearly something that we'll want to monitor over time. But it doesn't, even though I'm highlighting now the things that are not going so well, in that column you see a lot of conditions with negatives, and negatives with uncertainty intervals that don't span zero, indicating that there's real improvement, as opposed to these three conditions where we clearly see adverse trends happening. And so when you write a paper on GBD, if you want to talk about the changes in the disease itself, you should focus largely on the change in age standardized rates. That tells us, is the epidemiology of that disease changing? And is that due to changes in mortality or changes due to the occurrence of disease? It's also useful to look at the total numbers, but not so much to say what is happening with this disease in an epidemiological sense, but what is the likely burden of this condition on health services. Because the disease may be dropping in age standardized rates, but it may actually be still imposing an increasing burden on health services. And for planning purposes, particularly staffing levels or facilities, it is quite important to know which direction also the total volume of health loss is going. I'm getting a little stuck here with, oh, okay. Here I'm moving again. Let's look at this in another way. This now shows in the darker shade the proportion of disease that is attributable to those 88 risk factors that we quantified. And so you can see we know a whole lot about stroke, about ischemic heart disease, hypertensive heart disease, chronic kidney disease, diabetes, neonatal disorders, anemia, pneumonia, HIV, diarrhea, to a lesser extent, Alzheimer's, some of the cancers we know a lot about, but there are also a lot of cancers where we have relatively little knowledge of what is causing the size of the burden. And then whole sections like congenital oral disorders, gynecological disorders, headaches, a lot of the musculoskeletal conditions, and a very large proportion of mental disorders and skin disorders. We do not have the same level of information on what is driving that burden, and hence also likely to have less levers of how can we intervene in the size of the burden of these conditions. So if we look at the global DALYs attributable to level 1 risk factors, where we lump all risk factors into behavioral risk, metabolic risks, and environmental and occupational risks, then you can see that it's larger for the behavioral risk and sort of similar for the two other types of risks. And the total DALYs due to metabolic risk, like high fasting plasma glucose, high BMI, and high blood pressure increased by 31%. I'll just quickly show you a similar sort of ranking table where high blood pressure has overtaken air pollution, particulate matter pollution, indoor and outdoor. But looking here at the percent change in age standardized rates, then you can see there's a lot of improvements, but also notable things that are going up. High BMI, is a significant increase, not quite significant globally for high fasting plasma glucose, but certainly when we look at certain parts of the world, it would be. And then largely lots of things where there are, reasonable declines and improvements, more so in the ones that are on the environmental occupational side of things. Just quickly some maps. Where is the largest amount of burden from high blood pressure? You can see Eastern Europe, Asia, Africa, by and large, with much greater gains in reducing this burden in high income settings. Particulate matter, this big range from Africa across the Middle East into South Asia and East Asia. Partly due to the use of um, indoor fuel-based indoor cooking, as well as outdoor air pollution from using fossil fuels, but also in parts of Africa and Asia, the influence of dust from deserts. Smoking, still extremely large contributor in Eastern Europe, in Indonesia. The Northern Cape is well known for its very high rates of smoking. Greenland, but also you can see where all the tobacco is produced in the US. We have much higher burden values than in other parts of the world. And Scandinavia, Australia, New Zealand, and luckily large parts of Africa showing much lower exposure, as well as part of Latin America. Then high fasting plasma glucose in a lot of Africa, Middle East, and South Asia, Indonesia, but also very prominent problem in Mexico. Low birth weight and short gestation, by and large, a problem of sub-Saharan Africa, with Botswana being the exception in that part of the world. South Asia and poor places like Laos and Myanmar. And then high BMI, the very large influence in the US, in Mexico, in the Middle East, Southern Africa, more so in women than in men, but much less in much of Asia. But on the rise, as good as everywhere in the world. So just to finish up, important is that nearly half of global health loss is in principle preventable through modifiable risk factors. 46% in 2023. The top 5 risks are blood pressure, air pollution, smoking, high fasting plasma glucose, and low birth weight, short gestation, all with effective and cost-effective interventions. But we're falling short in giving good access and full access to quality care for dealing with these conditions. So focus on diets, on physical activity, tobacco control, and improving air quality are important things to think about. Then, some worries. The magic decreases in communicable maternal, neonatal, and nutritional disorders is under threat. It's fragile. We saw still a 26% decline since 2010, particularly diarrheal diseases, HIV/AIDS, TB, malaria, and neonatal disorders, but still at high levels in low SDI locations, particularly in sub-Saharan Africa and South Asia. But the bigger worry is that the recent cuts in health funding globally threaten to reverse some of these gains. whereas a sustained investment is critical to keep the momentum and being able to largely eliminate those diseases from the burden of disease, even in low and low middle income countries. Then rising non-communicable disease burden, almost 2/3 of global DALYs, and importantly, these metabolic risks, I think we have only 6 of them, they rose by 31% since 2010. And in particular, the rise of BMI and high fasting plasma glucose are very notable. Already talked about the rising burden of mental disorders, particularly depression and anxiety, with peaks among the youths aged 15 to 29 to 19 and 20 to 24, and much more in women than in men. And part of that is that women tend to react to stressors with what we call internalizing behavior, whereas men often externalize that, and that then shows up in greater rates of injuries or substance use disorders. So, it's important for health systems to realize the large size of the non-communicable disease burden, where possible, use the levers to prevent it through, tackling major risk factors, and depending on the condition, with early diagnosis, maybe through screening, and then good management of chronic diseases. So, even though we have these, over 100,000 data sources, it's still an enormous challenge to deal with, covering for all those diseases and causes of death data across the globe, and often to have to deal with all the variations in how data are collected, and, the potential measurement bias among all these sources. So any help that we can get to find new data, to think about what new causes and locations we could make estimates for, to more precisely correct for measurement area and capture the uncertainty within the burden estimates, are ongoing areas of priority, and where we can make fantastic use of the large GBD collaboration that you are part of. We've rather limited data on severity of conditions. We are putting quite an effort on trying to make improvements so that we can estimate this more often to be varying by access to care. But so far, because of data limitations, we have not been able to do that as well. And we currently don't deal with all the comorbidity, because the what we call dependent comorbidity, the higher likelihood of having another disease if you have one disease, we are not quite taking into account, and would like to be able to do that more formally. And that's going to be a big focus of our work in GBD 2025. And you've probably seen quite a bit about our forecasting work, and that will become more and more important, to look forward and say what is likely to happen in the next 20, 30, 40, 50 years, if we intervene this way or that way or that way, or if all these major catastrophes that potentially could happen. So you'll hear much more about that going forward. So I now hand over to Johan. So if you want to flag any major comments and questions that have come up.
Yes, thank you, Theo, for that presentation. And thank you, everyone, to those who've already put in your questions. For those of you who haven't, please feel free to use the Q&A function to put in your questions, but we shall start here already. First question is, could you help explain what it means to combine prevalence YLDs with incident YLLs to produce DALYs? Aren't these two fundamentally incompatible measures? Just want to make sure we sort out what that misunderstanding is there.
Yeah, well, it's not quite, as you call it, incident YLLs. I think the way I view it is that gap between the age at death and the ideal life expectancy is like a weighting for deaths at different ages. Because those deaths occur in the year of interest. And so we really want to, have a measure of what the amount of health loss is arising from deaths in that particular year, and combine that with the lived experience of disease at different levels of severity in our YLDs. So I don't see that being a problem.
Excellent, thank you. Another question here. Hi, Theo. The burden attributable to lead really popped up this year dramatically. Could you draw some lines on what the major factors are, also from the data perspective?
Yeah, I think what changed is that we did a major overhaul of the review of studies that look at the health effects of lead. And so the major health effects are in kids on intellectual development. And so the consequence there is increased rates of intellectual disability. But also in adults, the effect of lead on cardiovascular outcomes. And even though a lot of lead has been, phased out, like from as an additive for gasoline, it's one of those factors that accumulate, and that for lead, bone is a place where it is stored and can continue even if exposure was largely decades in the past. It can still have its effect when you grow older, and it does get released from the bone and starts influencing cardiovascular outcomes. So this is largely an update of the strength of the evidence of the health consequences.
Thank you. Considering that physical activity plays an important preventative role, how could the GBD methodology evolve to include more detailed subcategories of physical activity, such as type, intensity, domain, etc.? And what type of data or study designs would be needed to support this kind of refinement?
Yeah, physical activity is really hard to measure because, what we until now have done is rely on all these questionnaires, and there are different types of questionnaires that include different types of questions and concern different domains of activity, and they tend to be rather imprecise because they are based on recall. What we're currently considering is the increasing amount of information that we can get electronically on physical activity levels. So using accelerometer data, or all the information that currently you have on your watch or on an iPhone, and see if we can change the exposure to more measured things, rather than people having to report for all sorts of different activities how much activity they had, and all the impreciseness of having to measure it that way.
Thank you. We have a request for clarification here, asking why transport injuries are listed as separately from unintentional injuries, and why it's categorized.
Yeah, that's how we do it. uh, by and large, you would say that traffic injuries are unintentional injuries as well. But they are such a standalone category that we've decided to pull them out from the other unintentional injuries.
Excellent. A question here about other methodologies. So what about deploying more sophisticated techniques like ML models or stratification models, and which is already sort of available, and would that add value to estimations?
I'm not quite sure. When you say stratification, what you mean stratification of what? And when you say ML models, what do you mean with that?
If we could get a slight clarification on that question, we can loop back to it after the others here. Thank you. Another question here saying, wondering how we might include changes in not only access to care, but what constitutes care, particularly with telehealth and AI and other factors. Standards of care have changed and may influence things like mental health. And of course, not only social media for young people, but isolation. What is your sense in how like these things coalesce together?
Yeah, well, in terms of estimating the burden, we rely on prevalence surveys. And the factors that you are talking about might impinge on those prevalence figures. Um, Yeah, I think it's a sort of a secondary analysis then to look at what are the drivers of change over time in say mental disorders. But that is not if you like, a core GBD kind of analysis, but of course extremely interesting and of importance. And it might, with doing those sort of analyses on more recent data of mental disorders might give us a better handle on understanding the drivers of change in mental disorders. And so, maybe in some time in the future, we can, look at use of social media as a risk factor, or, general worries about the future, about climate change, for instance, as a driver of anxiety or depression. But I don't think we're there analytically to even start doing that. But extremely important and highly worrying that the rates are going up so quickly. Now, a word of caution there, that we can't exclude the possibility that part of that increase is due to a change in how people react to these standard questions that mental health surveys tend to ask, where there may have been, particularly among younger people, a greater willingness to declare symptoms and questions about symptoms of mental disorders, and that having an influence on the rates. Having said that, I think we should consider that being a possibility, but the changes are so large that, in my view, it's very unlikely that these measurement issues can explain the bulk of the changes that we're seeing.
Thank you so much. We have about 2 minutes left here for additional questions, if there are any. While we wait to see if there is anyone who wants to ask questions. Does not look like we have one question in here about the GBD compare, but it seems like that is being answered by one of our other colleagues. Here we go. We got a clarification on ML, which is machine learning.
Okay.
So the question is if there's anything
Yeah,
else.
but I can't really answer a question that is as broad as that. We would, have to look at, what the particular topic areas where these newer techniques could help elucidate things over, like changes over time.
Thank you. With that, we have arrived at the time for this session to end. I want to thank all of you for participating. The GBD literally could not exist without the help of our collaborators, and the kind of feedback and questions we get in sessions like these, as well as in other contexts, is crucial to developing our understanding and new methodologies and so on for the GBD. And it helps us to better address the health challenges we face both globally, regionally, and nationally. As I mentioned at the beginning here, we will share a recording of this session as well as all the other GBD 2023 in Focus sessions at the Collaborator portal, where you can also find a number of different resources related to the GBD. If you weren't able to get your question answered today, or you have other issues, questions, concerns, thoughts that you would like to share with us, you can email gbdsec@uw.edu, and we will be more than happy to help respond to you there. But with that in mind, I would like to thank Professor Theo Voss for presenting for us today, and I would like to once again say thank you to all those of you for being here today. We look forward to having you for the other sessions as well, if you're interested in those. And on behalf of IHME, I wish each of you a great rest of your day. Thank you.